Hey everyone, my name is Dr. Sudha Swaminathan. I am a nephrologist and a renal transplant doctor working at Fiona Stanley Hospital. In today's teaching session, we are going to talk about some basics of kidney transplantation care. So I'm going to talk about why do we perform kidney transplantation? Then how do we look after the patients immediately before the kidney transplantation as they come to the hospital? And how do we look after them during their stay in the hospital until they get discharged? So talk about peri-transplant care in the hospital of a kidney transplant patient. When patients reach end-stage kidney disease, they need renal replacement therapy, either in the form of dialysis or kidney transplantation. Less than 20% of those on dialysis are suitable to receive a kidney transplantation. What is the advantage of receiving a kidney transplant? We know that there is a significant improvement in quality of life. The patients don't need to spend 20 hours a week performing dialysis. In addition to quality of life, kidney transplantation also improves survival. The graphs here compare the survival of patients on dialysis with kidney transplantation. Y-axis represents survival. The graph on the left-hand side compares nocturnal hemodialysis in the dark line with live and deceased donor transplantation. The graph on the right compares survival on any form of dialysis compared with receiving a kidney transplant. As you can see from the curves, the survival on dialysis is inferior to receiving a kidney transplant. When you see the graph on the left-hand side that compares transplant with nocturnal hemodialysis, which is the best form of dialysis, where patients get on average 6 hours of dialysis at least 5 times a week. But we know not many people are able to perform such rigorous dialysis. With the nocturnal hemodialysis, the survival is almost similar to the deceased donor transplants initially, but as time progresses, the survival on dialysis drops. So, in summary, transplantation offers a better quality and quantity of life for our patients. This graph also compares dialysis with transplantation. Here, the y-axis represents relative risk of death. The dotted line represents the baseline mortality rate if patients are maintained on dialysis. As you can see by the red circle, the risk of death is higher in the first few days of receiving a kidney transplant. The survival on transplant equalizes survival on dialysis around the 3-month mark. Once you survive 3 months after transplant, then your survival is much better than being on dialysis. In this talk, we are going to focus on the initial high-risk period, the first 5 to 7 days after a kidney transplant, and how to care for these patients. When a patient arrives on the ward to undergo a kidney transplant, we need to make sure they are medically fit, they have no active infections, whether they are fit to undergo anesthesia. We may have to dialyze them. If they need dialysis based on their biochemistry, especially potassium, we usually give them a shorter hemodialysis session for example, 2 hours. We prefer their weight to be little higher than their ideal body weight, say as a rule of thumb by a kilo. If patients are on PD, we continue exchanges until they are wheeled to the operating theater. We usually do pre-op bloods as routine, chest x-ray sometimes, and an ECG. The patients are reviewed by the medical, surgical, and the anesthetic teams. We have to administer pre-op medications, immunosuppressions. It's a very busy period, but we are very interested in the key documentation of the pre-transplant weight and urine output, which is from the native kidneys, as these measurements will help us monitor these patients' immediate post-transplant progress. There are some special considerations. If a patient is receiving a live transplant, then we can plan everything. For example, the timing of dialysis, timing of admission, the medications, theater times, etc. But in case of a deceased donor transplant, we have to do everything in a matter of few hours. It's very important we keep our patients fasting so that they can undergo anesthesia. There are some high-risk transplants, such as ABO incompatible transplants or highly sensitized patients based on their HLA antibody. These patients need plasma exchange or an ABO column exchange prior to the surgery. In that case, we liaise with our apheresis unit. We try to avoid blood transfusions as much as possible, as they can increase HLA sensitivity and increase the risk of future rejections. Cartoon explains where the new kidney is implanted. Usually, there is an incision in the iliac fossa. The donor kidney is quite superficial. It is connected to the external iliac vessels. The new ureter is connected to the bladder directly. When patients come out of theater, they usually have central lines, some peripheral lines with fluids and medications running. There's a patient-controlled anesthesia, a urinary catheter. Sometimes they also have local anesthetic infused around the surgical wound for better pain management. The first 24-hour period following a kidney transplantation is very critical. The perfusion of the transplanted kidney during this period is very important. Hence, we want to maintain the blood pressure in the adequate range. We monitor the adequacy of the perfusion of the new kidney by regular blood pressure readings, urine output readings. We give the patients IV fluid replacements based on their fluid status and urine output in order to maintain the perfusion pressure. We do Doppler scan within 24 hours to check the integrity of the anastomosis and to ensure the kidney is adequately perfused. Sometimes patients develop delayed graft function, which means that the newly transplanted kidney is not functional yet. In that case, the urine output cannot be used to monitor the patient's progress or the adequacy of perfusion. In those circumstances, Doppler scans are very useful. Patients with delayed graft function might need to undergo dialysis until such time that the transplanted kidney starts to function. Next, blood tests. We perform regular blood tests to check their hemoglobin, which can give us information about postoperative bleeding, fluid status, etc. We also measure electrolytes. This will help us determine the need for dialysis or other replacement of electrolytes like potassium, calcium, etc. We also monitor the drug levels to ensure the immunosuppressive treatment they are receiving are within the therapeutic range. Pain management is also a key element in the care. We usually involve the pain management teams. If a patient's pain is not adequately managed, then the blood pressure tends to go up. Higher blood pressure can compromise the vascular anastomosis. Not only that, if pain is not adequately managed, then the patients are not able to mobilize. This increases post-op morbidity, delays recovery, and delays discharge. Then there is wound management, looking after the surgical wound, the staples or the stitches, looking for ooze, looking for signs of infection, etc. Usually the urine catheter and the drains are removed on day 2 or 3, depending on the clinical scenario. If a patient has got delayed graft function and there is no signs of urine output, then the catheter can come out earlier. This will be determined by the clinician. Patients usually have a double J stent in situ, which is removed 4 to 6 weeks post-transplantation as a day procedure. After the kidney transplant operation, the patients are usually discharged around day 5, day 6. Before discharge, they are given education about diet, their new medication. Usually, the post-transplant medications are vastly different from what they had been on previously before the transplantation. So, they do need education. They are followed up several times a week for the first 3 months in the acute transplant clinic. And after that, usually the clinic visits are spaced out to about 1 year time. They'll only be seen every 2 to 3 months. These are the common medications that the patients who received a kidney transplantation will be maintained on. That is the induction and the maintenance therapy. These medications will be explained in detail in a separate education session. These are some of the common side effects of the anti-rejection drugs that are used in the setting of kidney transplant. The commonly used anti-rejection drugs such as cyclosporin, tacrolimus, sirolimus, everolimus, etc., they have several interactions with other medications. Some of the medications are mentioned in this slide. It is very important to educate our patients that whenever some other doctor prescribes a new medication or tries to stop some of their existing medication, especially diltiazem, the patients need to alert the doctor that they are on anti-rejection drugs. This is a key message we all want to deliver to our patients. I hope you enjoyed this talk on the peri-transplant care of our renal transplant patients. Please let me know if you have any questions. Thanks for listening.